Good morning. This is Dr. Rutledge. I'm doing a run through for Dr. Kular's slide presentation for GOA entitled A Modest Proposal, the MGB for All Diabetics, question mark. Okay, this is a tailored MGB in the treatment of diabetes. And the MGB tailored BP limb length was between 120 and 350 centimeters. And this is a study of 570 patients that he was able to follow for 10 to 14 years. All of them have 10-year follow-up. Preoperatively, only one out of 570 patients had a hemoglobin A1C less than 7, that's 0.2%. 10 years later, after a tailored MGB, 85% had hemoglobin A1C less than 7, and 2/3, 60%, had a hemoglobin A1C less than 6. I mean, we're not allowed to say cure, but that's a really good HbA1c. The MGB with the tailored biliopancreatic limb length, that's the power of the MGB. It is unique amongst operations, and we're going to use diabetes as an example of that tonight. A warning, reminder, rising tide of diabetes, a local, national, and global emergency. Overall, 425 million people worldwide, almost 1 out of every 11 people is a diabetic. 2045, it may be up to 629 million patients. Frequently, it's a silent killer, but millions are suffering. And it's a massive burden on patients, families, and healthcare systems. What can be done? Well, let's look first at our host country, which is India. And 77 million Indians have this devastating complication. 1 in 11. Economic strain here is substantial, as it is in every other country in the world. The key for judging the intervention in this case, and in most cases, is the hemoglobin A1C. So for example, between 6.5 and 7, you're almost at the lowest risk possible. HbA1c of less than 5 or greater than 8 are extreme and usually results in complications or death. Something is going on badly, deranging the system. And research shows that HbA1c management can improve health and decrease complications and cut costs. Our hypothesis is simple: a tailored BP limb such that we can offer it to thin, obese, and super obese patients may be the solution for this problem. It's safe and effective and reduces the hemoglobin A1c tremendously, and we know from some data we'll show you that that changes the outlook for the patient. MGB is then a more effective and cost-effective solution. The world is about to change. This Kular Hospital study of 570 diabetics, the success with a tailored BP limb length, much different than some surgeons' performance of the MGB. It's effective in both low, medium, and high BMI patients. The MGB OHB is long-term control of hemoglobin A1c. Now here's a quick look at the 10-year data. And what you can see here is, look at this preoperatively. The hemoglobin A1c here is sky high. And for the next 1, 5, and 10 years, it's almost always, not always, almost always less than 7, less than 6.5, and in many cases, completely reverses the disease and its complications. The weight is also remarkable. These weight changes when you tailor the BP limb length. We see that this is the preoperative weight distribution. So from 80 to 270 kilos. And look at all the numbers of the post-op hemoglobin A1c levels. Everyone, I'm exaggerating, not everyone. There's 1 or 2 people outside here. But almost everyone is normal. They're normal weight. They're in the normal weight range. By tailoring the BP limb to the patient's weight and illness, you can get a remarkable result, which is a near normal weight for 1, 5, and 10 years up to 14 years in the study. Here's the hemoglobin A1C broken down. You can see that preoperatively, almost no hemoglobin A1C patients if they're hemoglobin A1C, and postoperatively, the number of patients over hemoglobin A1C is down to 15%. And remarkably, 60%, 67% have a hemoglobin A1C less than 6. What happens to the hemoglobin A1C? What we can see here for the 1, 5, and 10-year values is a tremendous decline. The decline is proportional to the hemoglobin A1C's biliopancreatic diversion. 90% of patients have a hemoglobin A1C less than 7. We're not allowed to call that a cure, but boy, it smells like it to me. Successful and safe treatment with a thin diabetic as well as medium and heavier patients. Let's look at it. These are the BMI and weights between 60 and 100. They're relatively lower weight. On the other hand, we have treated them with a 120 centimeter bypass. Let's see what happens. First of all, they don't get too thin. The average weight loss is only around 15 kilos. And what we find is the preoperative hemoglobin A1C in this group was almost 8 on average. And after 1, 5, and 10 years, it's between 6, 7, and 6.9. A fantastic decline from their preoperative values. A decline, which we're going to see in a few minutes, can save lives and a good deal of suffering and costs. Here's an overall distribution, and you can see because it's a smaller bypass, we don't get everyone down below 7, because the power of the MGB is muted in part because of the low weight. But still, these numbers are remarkably better than what they were preoperatively. Before surgery, this is the before surgery, so many of them were in the 8 range, and postoperatively, most of them were in the 7 range. That's one way to think about it. Preoperatively, only 1 patient was below hemoglobin A1C of 7. Postoperatively, 40% are less than 7. And so the mean has gone from 8 down to 7.1. Longer BP limb results in larger decrease in hemoglobin A1C. And so we see that here as the biliopancreatic limb length increases, HbA1c level change increases. So the delta hemoglobin A1C goes up with a longer bypass. And it's so precise that you can use that when you decide to operate on the patient. Again, longer BP limb, larger decrease in hemoglobin A1C. That's the power of a tailored BP limb length in the MGB. Now we're going to look at a couple of articles. This is a study looking at the costs based on hemoglobin A1C. So if you look, this is an estimated annual cost between 11, 12, 13, 16, 20, 21,000 based on hemoglobin A1C. So we use those numbers and put it into our group of patients. If you look at our group of patients, here is the hemoglobin A1C, and here's the estimated savings. So we save more for sicker patients. But even for patients with a relatively lower starting pre-op hemoglobin A1C, we're talking about savings of $250, $500, up to $1 million. And the total estimated savings for the entire 570 patients for 10 years is $452 million. It's a gigantic savings for 1 MGB done in each of these patients. There's not much change in albumin. and we can talk about that, but we don't see that. And so we conclude by saying, imagine the MGB, a new hope for diabetics. The diabetes crisis is real, and the MGB, which we've now used for many years, we know we can tailor it to the thin and to the overweight diabetic. We suggest that we lead the way. We can do further research and advocate for diabetics having access to the MGB. It will save them money. It will save governments money. It will save them legs and eyes and life. We here today may help decrease the burden of diabetes in our own countries and the world. Thanks very much.